Good evening, everybody. Today is Sunday, September 19th, 2021. Today is a case list defense webinar. With a show of hands, can I see if everybody can hear me? We have some good audio. Please raise your hand. Okay, very good. Thank you so much. Just before we start, does anybody have any questions about anything in regards to the exam, anything you've heard in the webinars before we start? I'm just going down the line here. Okay, I see that nobody has any questions. Okay, I see that Zishan has had his hand up. Is he interested in getting in the hot seat? It says you're self-muted, Zishan.
Can you hear me?
Yeah, you're interested in being in the hot seat?
Yeah, I just wanted to go over one of my cases from my cases.
Perfect. So let me go ahead and grab that there for you. Hold on, did you submit your case list?
Yes, ma'am. This would be under the gynecology.
Okay, hold on a second. Just trying to get to the case list here. Give me a second.
No worries.
You said gynecology, correct?
Yes, ma'am. It's under diagnostic laparoscopy.
Okay, hold on. Let me see. I'm looking for your, it's a big list, so bear with me here. Okay, here it is. Which number is it?
I don't have the exact number. It's the initial NH. That's the 6
that I don't have. I don't have the initials because this is de-identified. So it's what
It's a 8 centimeter cystic teratoma.
She's 34 years old, para 0?
Yeah.
Okay, hold on a second.
Yeah.
See if I can put it on my screen here.
I wanted to ask this one question before we start was, whenever you're ready.
Give me a second. I'm trying to get it on the screen here for everybody to see. Okay, so what is your question?
Yeah, I mean, for a mature cystic teratoma, my concern here was how aggressive would I seem when you see a diagnostic lab RSO, because I was not able to save any of the ovarian tissue and strategies to be able to defend that is what I'm concerned about. That may be considered too aggressive here.
So let's put it this way: was the entire teratoma encompassing the ovary?
Correct.
Right. So that's how you defend it. You say,
Okay.
you know, I attempted to see if there was any clear ovarian tissue that could be salvaged, and I could not see anything, and that's the decision that I made to proceed with the RSO.
Okay.
You know, that's the decision you made at that time. So.
Correct.
So nobody can fault you for it.
Okay, but they want to see that at least I even attempted, or simply my.
Yeah, you could say that. You could say assess the situation, you know, to see if I could do a cystectomy, and it was very clear to me that there was no ovarian tissue that I would be able to leave behind, or whatever the case that you decided during the case.
Okay.
And unfortunately, it is a mass that needs to come out, right?
Right. Absolutely.
So you just defend what you did. Nobody can fault you. Some people may disagree, but they weren't there, and you just have to defend why you did what you did.
And the idea of this is something that needs to come out, but the decision of how long to wait. For this patient, this is somebody who had incidental finding, with a car accident, and then came back saying, hey, the ED said I need to follow up because I have a mass. She was initially not symptomatic, but way about 6 months later, what became symptomatic, and that's when we made the decision that I go in there.
Right. I mean, it's a good size mass too.
Right,
It's not a
right.
2 centimeter or 3 centimeter, it's 8 centimeters. So, I mean, her risk of torsion increases, of course. When you were saying we decided, you must say in the exam, I decided.
Okay. All right.
Everything's I did this, I did. I know it's hard, because you work, you're a junior, associate in your practice, and you have your senior, partners, but it's I did this, I did that.
Okay. Okay, great.
Yeah, but that's a good size mass. So, I mean, you can't, you're gonna sit on it for 5 years? No.
The same thing happened in my case list later on, where I had somebody with an ovarian torsion, who had a history of a teratoma, and at that point it looked dusky. When I went in there, it did not change color at all, and I couldn't discern any tissue. So I did a RSO, but it did not come back necrotic. But it did say obviously it was about a 8 centimeter, that one mature cystic teratoma as well. Same
Well,
argument would
you say that what you're saying right now, that's your defense on why you decided to remove the ovary. That being said, there's been a lot of and of course in the exam you don't say literature, studies, and those type of things. I know there's a lot more individuals who focus on pediatric and adolescent gynecology.
hmm
So they have done a lot of cases, and there are a lot of case list reviews type of things and case reports of patients with literally, I'm not going to say necrotic, but very dark appearing adnexa that were torted, and they untorsed the ovary, and they take out the cyst, and they leave the ovary behind. And in about 85% of the cases, even though it was dark and dusky, about 85% of the time, follicles do start forming again on
Okay.
the ovary, with ultrasound follow-up. But
Oh,
that's, again, that's a pediatric gynecology uh, trained individual who they made these decisions. I can't fault you by being a generalist, and you untorted it, it still stayed dark, you were concerned that it was necrotic, and you made that decision. How old was the patient? Which patient's this?
okay. Let me see. Um,
Which heading do you have it in?
see. Okay, one second. I think this was one of the emergency ones where they had, yeah,
Okay.
under the emergency. Let me see.
Yeah, 6 centimeter.
6 centimeter, correct.
Yeah, got it here.
On ultrasound, we thought it was 8, but yeah, it ended up becoming.
Yeah, that's fine. I mean, she's had kids before and everything. I mean, I don't think anybody will fault you. I can understand if she was 13 years old or something like that.
Okay. Okay.
So you say that you detorted the ovary, it still was dark, you were concerned for necrosis of the tissue. But that being said, like I said, a lot of pediatric gynecology case reports and stuff like that, they thought the ovary was gone, they detort it, they take out the cyst, and with follow-up ultrasound, they see follicles forming in the ovary that was affected.
And so if they ask me, they're like, okay, what if this patient was 18? Um, would you have done the same thing? I would discuss what you're saying at that point. That my main thing is there any discernible tissue for me to be able to separate? As this ovarian torsion was a teratoma as well, and a good size, and I couldn't discern any tissue there either, which is why I
Yeah,
went for.
for sure. Exactly.
Okay,
And then
okay,
there's nothing wrong also by saying, and I don't know, I mean, I'm sure it's happened to a lot of people in the process of their studying, that you realized you were doing one thing before. I've been doing these reviews and these webinars and mock orals and all that for several years now. And years ago, we didn't do, bilateral salpingectomies for tubals. But then it started being the standard of care. And I know of case of individuals in their case list, they initially did, a particular type of tubal ligation, and then it's part of their case list, and then the other half is the bilateral salpingectomies. And you easily say, as I was preparing for the boards and I was studying, I realized that the standard of care has changed, and that's why you may see part of my case list being a tubal ligation versus bilateral salpingectomy. There's nothing wrong with saying, as you're prepping and preparing and reading, you realize that the standard of care has changed, or there's something better that you can do, and you say, and I've now changed since I've changed my practice. Nothing wrong with saying that.
Okay.
Because things change all the time, right?
Yes, ma'am.
In medicine. So as long as you defend why you did what you did.
Thank you.
Make sense?
Yeah, absolutely.
Now, do you want to go over a particular case, or you're good with the questions that were answered?
If we have time, let me get one second. It's one under the intraoperative complication or postoperative complication.
So post-op, intraop.
I think it was the post-op complication.
Post-op, hold on. Got it. It was a THBS, oliguria.
Yeah. Let me get there to my case real quick.
Okay.
Okay. Yeah.
All right. So tell me about this case.
Here's a patient that came to the emergency room, and I was given a phone call from the emergency room saying this is somebody who incidentally came in for annual at a family practice clinic and was found to have a hemoglobin of 3.5, and they said for the patient to go to the ED for a blood transfusion. She was given 3 units while I was given a call and to evaluate for the reason, and there was then a pelvic ultrasound with a finding of a 10 centimeter leiomyoma. Initially, there were much more blood units ordered. I had canceled after the 3 that were given to try to assess the cause, finding it was actually iron deficiency anemia, and subsequently replaced the patient's iron as the ferritin was quite low. Got the patient to be at a stable hemoglobin level before she decided she wanted surgical management because we could not.
And how long did that take?
It took at least about 8 weeks between her first.
How did you manage? I'm assuming she had heavy bleeding with her periods, or irregular heavy bleeding. Am I correct?
Correct.
So how did you manage that abnormal uterine bleeding?
For when it was acute abnormal uterine bleeding, I had given Provera 20 TID for 7 days, but in subsequent menstrual cycles, she continued to have heavy bleeding and was given the option of medical management, but because we continued to fail, she decided she preferred
what type of medical management do you offer her?
Besides being on regular OCPs, it was a Provera 20 TID for 7 days for acute bleeding.
And then she was started on birth control pills?
Yeah, letting her know that the size is so significant that it would not necessarily be decreasing, but if it can control bleeding.
What other options are available for treatment?
Oh, besides medical management, if she continues.
No, I'm talking about medical management. Medical management, nothing surgical.
Oh, nothing surgical. She could also be given Depo-Provera shots. If it was acute bleeding, we can do IV estrogen can be given. She can also be given. Go ahead.
No, go ahead.
Okay. Besides combined OCPs or just progesterone or IV estrogen for acute bleeding, she can also be given a PO-TXA.
What's the dosing on that?
Dosing on that is, I'm sorry, I'm blanking on that right now. I can look that up. I'm gonna have to look that back up again.
Okay, what other options are there?
We can also offer a uterine artery embolization if the amount of bleeding continues to be heavy as well.
So what are contraindications to a uterine artery embolization?
Contraindications include someone if they desire pregnancy, is one of the contraindications due to the risk of possible association with a Nacrita if she were to have a previous subsequent pregnancy.
How would it cause a Nacrita in a subsequent pregnancy?
With the association is if someone had a urinary artery embolization and had a previa, the chance of Nacrita goes up significantly. But the exact mechanism, sorry, I don't know.
What other contraindications to a uterine artery embolization? Are you still there,
Yeah, I'm
Sishan?
there. I'm sorry.
Okay,
I can't think of any more contraindications.
okay, so after you discussed the medical management, how did you discuss with the patient surgical management?
And I discussed with the patient that the options here surgically can be a myomectomy versus a hysterectomy. But counsel is saying that a myomectomy would be more difficult just because of the size of, and if it's all encompassing of the entire uterine cavity, may make it more difficult and a higher risk also for bleeding as well. But because the patient did not desire any children or pregnancy, she decided to have a TH.
So let's say, then we'll change the story a little bit. Let's say this patient was 33 years old and had the 10-centimeter fibroid and had never been pregnant. How would you have managed that patient? She wanted to save her uterus.
I would let the patient know that that there's still a risk of heavy bleeding, but we can attempt a myomectomy, and that there's ways of sort of reducing bleeding intraoperatively, and we at least attempt
So
the myomectomy.
how would you do that?
When we're in the case, I would, due to the size, would do a XLab with the myomectomy and be injecting vasopressin diluted into different aspects of the psoriasis and the myometrium, and then slowly begin an incision on the fundal aspect of the uterus for this patient, if that were the case, and then slowly try to carve out the fibroid.
So what other options are available to control the bleeding or decrease your bleeding during a myomectomy? So you can use you said you could use a vasopressin. Is that what you said?
Yes, correct.
Okay. Any other options?
You can also give 1 gram of a possible TXA prior to the start of the procedure.
Okay. Anything you could do intraoperatively?
Besides the vasopressin, I'm not. You can actually also I'm blanking here. Pre-pressure.
So you told me you would give her. Okay, put pressure around what?
The isthmus or the body of the uterus while you're dissecting out the fibroid from the normal tissue.
Okay, and you said that you would get TXA. What's the mechanism of action of TXA?
Yeah, I'd have to look that up one more time.
Okay. So continue explaining to me what happened in this case. It looks like you had a complication.
Right. So when we performed the THBS, the next day I'd noticed that the patient did not have sort of adequate urine output. I was looking for
So what's adequate urine output?
half a cc per kilogram per hour for the patient, and so roughly would have been around 35 for this patient, and patient didn't meet that, and so I had checked her blood pressure. It was hypotensive. Her mean arterial pressure was less than 65, so we had checked the orthostatics, and so then there was a concern that possible for hemoperitoneum. And so we had done.
So what was her blood count at that time?
Blood count at that time. So prior to surgery, it had been an 11. By the next morning, it was roughly around 8, so hemoglobin of 8.
It was 8. And what was her estimated blood loss during the procedure?
Less than 500 cc's there during the procedure. I will have to look that up. Obviously, I don't remember that exactly right now.
So you did not believe that the hemoglobin of 8 was consistent with the amount of blood loss that you had in the case?
Correct. I was definitely concerned.
And then you had a CT scan that showed the hemoperitoneum. How much? Like, was it a large amount, moderate?
It was a large amount, and there was an attempt at that point, actually, to if it was recognized as source, to try to do a uterine artery embolization, but the interventional radiologist could not find the source, and so a decision was made then to do an X-lab. And then when we performed the X-lab, the left ovary, to my surprise, was and bleeding. And
So the ovary itself was bleeding?
Correct. Yeah, that's where it looked like it did. Right where the ovary was, that's actually was where the bleeding was coming from.
And you couldn't just cauterize it or oversew it? You had to take out the ovary?
Yeah, we tried to fill it and try to control that bleeding, and that's when.
How did you control the bleeding?
First, we tried using basic Bovie cautery, and at that point, we also tried figure 8 stitches as well. We weren't able to control the bleeding then.
So then the decision was made then to take out the left ovary.
Correct. Now, where my concern here is when the paths came back, I was a bit concerned how we did not, my partner and I, when we did the surgery, did not see a corpus luteum cyst, which was where I'm concerned. We had called the pathologist to confirm that finding, and they were confident that there was a corpus luteum cyst there, ovary with the.
And what was your concern with the pathology? Just didn't look cystic.
Correct, because the area that we were trying to control bleeding, we didn't actually see there was a grossly a corpus luteum cyst or area that was bleeding that was coming from a cyst. We thought it was actually coming from the ovary.
And then she got 2 units. And then what was her blood count like the next day?
The next day, it was a 9, hemoglobin of 9 at that point.
And how much hemoperitoneum was in the abdomen when you removed it during the surgery?
It had to be at least 1.5 liters of blood in the abdomen.
So she just had oozing or active bleeding from the ovary?
It was actually active bleeding from the ovary.
Wow. So tell me, what are the different types of transfusion reactions that can occur?
You can have trolley, you can have an anaphylactic reaction, you can have post-transfusion, just a simple fever from the transfusion. That's all I can think of for right now.
So how do you treat the simple fever?
Prior to giving blood products, my practice would give 25 of Benadryl IV and then 1 gram of Tylenol as well.
And how do you treat anaphylactic reaction?
Um, I have to look that up. I mean, at least we start with also you giving epinephrine, but the exact steps I need to look that up.
Okay, let's stop here. All righty. A very good, interesting case. Very interesting case. So to decrease bleeding in a myomectomy, the vasopressin, you can place a tourniquet around the uterine arteries. So you were in that right direction. You can use a cell saver. The dosing of TXA is 1,300 milligrams 3 times a day for 5 days. That sound familiar?
Correct.
And mechanism of action, it forms a reversible complex that displaces plasminogen from fibrin, resulting in an inhibition of fibrinolysis. And it also inhibits proteolytic activity of plasmin, whatever that means. There's 4 different types of transfusion reactions. You have the simple febrile illness, which is the most common, and it's caused by the antibody reaction against donor leukocytes. It's self-limited, and you give Tylenol for treatment. An allergic reaction, which is urticaria during transfusion in the absence of other symptoms, allergy to plasma proteins. You treat with antihistamines, and you may complete the transfusion. Then you have your anaphylactic reaction, leads to bronchospasm, wheezing, collapse, treat with epinephrine. And then you have your hemolytic reaction, which is the worst. And that's the recipient's antibodies induce hemolysis of donor RBCs. ABO incompatibility could occur in 1 of 4 million transfusions. The mortality is very high. The activation of a coagulation system by massive RBC destruction, inducing DIC. Renal injury from occlusion of renal microvasculature by the RBC debris. You stop the transfusion, support renal function with IV fluids, mannitol, and Lasix. Also, another thing you could do in order to increase somebody's blood count with a fibroid could be Depo-Lupron.
Can you repeat that one more time?
You could use Depo-Lupron to shrink your fibroids and hopefully control your bleeding. And I know we don't do that many vaginal hysterectomies as we did 20, 30 years ago. But I know as a resident, we used to give, Depo-Lupron in order to shrink the uterus some more so we can do the procedure vaginally.
What do you think of the pathology there of the hemorrhagic corpus?
I didn't even think about it, to be honest with you.
Okay.
I would not worry about it. I mean, she was bleeding. You tried to stop the bleeding. It didn't work. I mean, she had 1,500 cc's. That's a good amount. So
Right.
something had to be done, you know?
Okay.
Yeah, I wouldn't fault you for it. Now, if she had cancer or something, that's different, or borderline or something, but she didn't, thank God, so.
Okay.
All righty.
Thank you. Thank you.
Other questions? Good job. Interesting case. Any other questions? You're good,
Yes, ma'am.
Deshaun?
Thank you.
All right.
Thank you so much.
Good job. Thank you so much. Tamara, I'm heading over in your direction. It says you're self-muted. Are you there, Tamara? There you go. Can you hear me?
Yes.
Do you have a question?
Yes, I
You're
can.
interested in participating?
I'm interested in participating.
All right. Did you submit your list?
Yes.
Okay, let's go ahead and find that. Any particular case that you're
No.
worried about, or
I just need.
I'll do whatever? Say again, I'm sorry?
Yeah, whatever. Yes, whatever.
Are you a generalist or a specialist?
Yes, I am.
I'm sorry?
A generalist.
You're a generalist? Okay.
A generalist, yes.
All right. Let me just take a look here.
Okay.
I just turned my screen off so I can like look things slow.
Sure.
All right, let's do case 4.
Okay.
Can you discuss with me
All
how
right. This,
you, go ahead. Can you see the screen?
yes,
Are
yes,
you
I
there?
can.
Okay, so case 4.
Yes. Can,
Can you tell me how
mhm.
you counseled the patient in regards to her different contraceptive options?
Yes. So usually with patients that are interested in contraception, I will let them know everything that is available to them. So I will start with what they'll like from what works not quite as well, but is effective to the things that will work the best
So
for
by
them
saying does not
and be
work
the
as
most
well as,
effective.
like, can you tell me that? What does not work so well and is not
Yeah,
effective?
um, so it's not as efficient. So things like condoms, oral contraceptive pills, those are going to really depend on your ability to take them almost perfectly to have the best outcome for preventing a pregnancy. And then moving forward to long acting, reversible contraception, so Nexplanon, the different forms of IUDs, and
So the
letting them
Nexplanon.
know all of the.
So with the
Mhm.
Nexplanon, what is the mechanism of action in Nexplanon?
So the Nexplanon suppresses ovulation, and it does. It affects the endometrial lining as well. I would believe it makes it not as hospitable for
So what is its
fertilization.
main mechanism of action?
Ovulation suppression, I believe.
And what does the Nexplanon contain?
The Nexplanon is contains 68 milligrams of levonorgesteral.
And how many years does it last?
It is FDA approved, I believe, for 3. It has been shown to work up to 4 years.
Okay, so continue with your counseling of the patient.
Right. And then I will tell them permanent options. More likely they're not looking for that, but I always run through the entire process for them. If they're looking for something like oral contraceptive pills, I'll go over the different forms, if it's going to be progesterone only versus combined with estrogen and progesterone, and discuss appropriate use, things that may make them not as great a candidate for the oral contraceptive pills versus another option, and then risks and benefits associated with the oral contraceptive pills. And I'll do the same with each of the forms of contraception.
So what are contraindications to IUD?
So there are few contraindications to IUD. If they went with a copper IUD, the main one I can think of is Wilson's disease, I believe. That is the copper sensitivity. Other sort of contraindications if they have an active infection. So like active gonorrhea or chlamydia, active PID, if they have a purulent cervicitis, that would not be available for them to be placed at that time. Or pregnancy. Yes, that would be good.
Any other contraindications? You said pregnancy, anything else?
Nothing else that I can think of right now.
And how did you discuss with the patient? She got an IUD. Which IUD did she receive?
This patient received a mirena IUD.
So can you discuss with me the different, you said you had the Paragard. Can you discuss with me the different progestin containing IUDs and how you counseled the patient on which one to select?
Okay, so starting with the least, I'll say there's the Skyla, and that one lasts 3 years. It is one that a lot of people, if they haven't had an IUD before and are concerned about it being something that would cause them pain, it's something that I can offer them because it is a little smaller than the others. And that one contains the least amount of the progestin hormone. And then the next would be the kylena, and that one lasts 5 years, and it has more progestin hormone than the skyla, but less than both the lyleta and the mirena. The lyleta lasts 6 years, and the mirena lasts now 7 years, and they both contain the same amount. However, the mirena will give them more of the hormone daily versus the lyleta.
So when
usually
you say,
patients that
go ahead.
Oh, I was just going to say usually patients that I have, if they have heavier bleeding or are interested in having their periods become lighter and or hopefully they want to become amenorrheic, I will tell them to go more towards the lyleta or the mirena because they would be getting more of the hormone.
So do you know what the percentage of amenorrhea with the use of the mirena is?
It honestly isn't as much. I think it's only like 10% or something.
And what about with the skyla?
The skyla maybe 50%. I mean,
So 50,
yeah.
So 50% of
Maybe
skyla users have amenorrhea?
5%. No, 5% maybe. I know it's less.
And then 10% of mirena users.
10 or 20%. I'm not sure of the number.
And how much? So what progesterone is contained in the mirena?
It is the levonorgesteral progestin.
How many milligrams?
That one in total contains 52 milligrams. Yeah.
And what about the skyla?
The skyla, 52, 14 or 15, around that.
What do you mean by 14?
Milligrams.
So it contains 14 milligrams of the what type of progestin?
Of the levonorgesteral.
Okay. And then why did the patient decide on the mirena?
She had actually come in with the idea of wanting the mirena, and we discussed all of the other options to make sure that that was what she had wanted. But she had friends that had the mirena IUD, and they all seemed satisfied with it, and she decided that she was okay with that option as well.
So seeing that she is nulliparous, was there anything that you did in order to ease the insertion or make it easier for the insertion or less painful for the patient? And if not, what can be done?
Yes. I actually had her take Cytotec or misoprostol. I had her take that about 12 hours prior to her appointment, and that was used to
what dosing?
help soften the surface.
What dosing?
I gave her 200 micrograms of Cytotec.
12 hours before the
200
procedure?
micrograms of them. Yes.
Any other options that are available?
Well, just mechanical dilation you can always try during the procedure. using a Hagar dilator. Other
Anything else?
things, not that I can think of.
So go through with me the process of your IUD insertion with the patient.
Okay, well, I will first ask the patient if she has any more questions before we get started, and then I would get her positioned appropriately and make sure that I have good lighting so that I can see everything. And then I'll place the speculum, make sure I have a clear view of the cervix, and make sure that it is as straight or as midline as possible for the patient's anatomy. And then I will clean it. I clean it with betadine using 2 swabs. And then I use a single tooth tenaculum, and I grasp the anterior lip of the cervix. And then I will use a Hagar dilator and just go through the internal os until I'll usually use that as a sounding as well, so I can see exactly how much.
You use it. What number size Hager dilator do you use as your sound?
It's a 4.
Okay. And how do you know, because the Hager dilator doesn't have any numbers on it, so how do you know how far to place? Well, explain to me how you do your process.
Sure. So I'll place it until I feel that I'm at the fundus, and then I use my finger to mark where I got it, where the cervix ends, and I will use that to measure actually on the container for the mirena, where they have the measurements there. And then I will set up the mirena so that the flange is appropriately measured to the measurement that I got. And then I place the mirena. I'll put the catheter into the uterus until I get to the fundus, and then I pull it back about a centimeter, and then I'll release the mirena and push it up to the fundus, and then I come out and cut the strings.
And what do you tell the patient after the procedure's over? Did you educate her on any specific things?
Procedure, yes. So after the procedure, depending on, like, say if she had come in on her menstrual cycle, I will let her know that she is okay to have intercourse and be protected. Otherwise, I have her wear or use backup protection for the next 7 days after placement. And then I give her just precautions to look for any fevers, chills, any foul smelling discharge, any heavy bleeding more than soaking 1 pad in an hour, anything along those lines, to go straight to the emergency room. And
now, do you educate your patients on checking the string?
Yeah, I was just going to say that. I'll also educate them on their strings, and I'll usually suggest they check it perhaps once a month or so, or if they have any concerns, and I'll let them know how to go all the way back and make sure that they know what the cervix should feel like so that they're able to appropriately locate the strings.
And do you follow up with the patient?
Yes, I do. I have them come in 2 to 4 weeks after placement, and I just make sure that I see the strings on speculum exam, and then I do a transvaginal ultrasound to make sure that I see that it's laying appropriately.
Do you do an ultrasound the day you put it in?
Usually, no.
So why do you do the ultrasound when you do your IUD check?
Well, more so, I feel like by that time it should have settled into place, and it would be laying as it would lay from then on out.
But if the strings are cut, like how long do you leave the strings? When do you, like, how long do you cut the
I'll
strings to?
usually leave them about 2 centimeters.
So if you examine her in her IUD check and that the strings are at 2 centimeters, isn't that enough to
Then
tell
it,
you that it's in the it hasn't
yes.
moved? So why do the ultrasound?
I don't know.
Because you charge her for it, right? You charge her
Yeah.
for the ultrasound, correct? So what's the indication of doing it?
Well, I usually just her IUD check, but I guess it doesn't have to be necessary.
All right, let's stop there. What do you
Okay.
think? You stick your guns. You do the ultrasound because you do the
Yeah.
ultrasound. I actually do an ultrasound
Okay.
the day I put it in to confirmation that I didn't perforate her. And
Okay.
and I had to defend why I did that. Nobody asked me on the exam, but when I did all this exam pro webinars and mock orals and all that, everybody, all the faculty always asked me, why do you do that? Why do you do that? Is that standard of care? I go, no. But on the other end, when I get called by a lot of primary care doctors because they perf somebody and I got to take the patient to the operating
Right.
room, you know what I'm saying? So if I can confirm to the patient, like, look, here's your uterus. I'm not saying what you're doing is
Yeah.
wrong. You just have to defend what you did.
Yeah.
That's the key. I can't say what
So
you're doing is wrong as long as you
yeah.
defend what you did and in your mind it is correct. And they're going to try to change your mind, but you got to stick
Yeah.
with your guns. You were going to say.
Okay. Because if I were to say, because it does sort of help put the patients at ease as well.
You could say
If
that
I'm,
too.
so
Yeah.
I'm, I could say that like I'm confirming it for myself as well as for the patient that know that they have
Oh
an
yeah, for
appropriate.
sure. But be prepared to say, do you bill for it? Because that's what they did to me.
Yeah.
The faculty. I never got asked on the exam, but they can bring that up
Right. Okay.
because it's not
Okay.
something usual. I'm not saying what you're doing is wrong because I do the same thing, but I do it the day I insert it. And I do it
Okay.
myself. I don't send her to the radiology suite. I do it myself
Right.
right there
Right. I do it
after I
myself
put it
too.
in. Um,
Okay.
don't forget severe distortion of the uterine cavity is a contraindication.
Yes. Yes.
Unexplained abnormal uterine bleeding. Okay, so the levonorgesteral is, you said it had 52 milligrams of the mirena. And the amenorrhea rate, according to up to date, is 20 to 40% of the lyleta and mirena. The kylena
Okay.
contains 19.5 milligrams, and that's 17.5 micrograms released daily. And as you have it in place, it decreases to 7.4 micrograms daily. And the amenorrhea rate there is 12 to 20%. And then your skyla is 13.5 milligrams, and it releases 14 micrograms daily, which decreases to 5 micrograms a day as the longer you have it in place. And the amenorrhea rate of the skyla is 6 to 12%. So if somebody says, I want the greatest chance of amenorrhea, you should put in either the mirena or the lyleta, right?
Okay. Yes.
Right. And another option to make it easier to place is to place it when you're having your period.
Right. And when I had said, when we were talking, when I was telling you about like backup contraception, I remembered that because I was saying if I had placed it while she was on her period, I was like, oh yeah.
Yep. And don't forget you did a pregnancy test.
Yes. Yes.
Never forget your pregnancy
I
test.
do.
Not that you need to, because when I started
Yes.
training, it wasn't, I mean, because it was just maybe 5 years ago that everybody is a candidate for IUDs, but 20 years ago that was not the case. You had to have one baby, you had to have a gonorrhea and chlamydia that was negative. It was, had to jump a lot of hoops in order
Right.
to but things have changed a lot in 20 years, put it that way. Other questions, but very nice. Good job. You see how they can ask you just about
Thank you.
anything? Does it really matter what the
Anything.
content milligrams of a mirena is? No, but they can ask you, and if you can get those bonus points, the better. You're correct. The Nexplanon does contain 68 milligrams of etonogestrel. So you were correct there.
Okay. Thank
Other
you.
questions? Okay,
No, I think
good
that
job.
is it for now. Thanks.
Okay, very good. Good job. Thank you for participating and being in the hot seat. I'm going towards Jennifer here. Says you're self-muted, Jennifer. Can you hear me, Jennifer? Says
Hi,
you're
can
self.
you hear me
Can you
now?
hear me now? You hear me?
Yes, I can hear you. Can you hear me?
Do you have a question? You want to participate?
Yes, I want to participate.
All right. Did you submit your
Yes.
list? All right. Let's go find it. Are you interested in a particular case?
No.
Anything? Any particular section?
I would prefer GYN, but we can do whatever.
Okay. No, we could do GYN. It's up to you. Look at that. You're first on the list. Check you out. So I'm just going to look through your list here. Okay. I'm just going to black the screen here for a second.
No problem.
Are you a generalist or subspecialist?
Subspecialist.
What do you do, my friend?
I'm an MFM fellow.
MFM. So of course, OB is of no value to you. Right?
Yeah, it's not the hardest one
You
for
should,
me.
you should be schooling me, right?
Maybe.
Perhaps. Let's see. I'm here looking. So that's why GYN is important for you.
Yes, thank you.
Case number 9. You can see the screen?
Yes.
Okay. Can you explain to me how you go into the abdomen laparoscopically?
Sure. So I prefer to use the Varies technique. So once the patient is asleep on the table, she's prepped and draped, timeout has been called, then I would, myself and the assistant would elevate the area around the umbilicus and then insert the Varies needle. I use the saline drop test to confirm location after I hear two sequential pops to confirm location. If there's easy passage of the saline into the abdomen, then I feel I've confirmed placement, and then I would connect the Varies needle to the gas to evaluate the pressure for insufflation, and if it was like under 5 millimeters of mercury, I would continue knowing that I had successfully placed the needle for pneumoperitoneum.
And go ahead.
Oh, no, then I would proceed with placement of the camera port by making an incision in the umbilical fold using a scalpel, and then placing the port with the camera through into the abdomen to then visualize into the abdomen.
Like with an OptiPort?
Yes.
Now, how do you confirm or how do you know that you didn't injure, let's say, bowel during your entrance? with the varus?
So yeah, so you know, it's possible. That's why I do the saline drop test to confirm the location, and that's why I also check the pressure upon entry and placement of the pneumoperitoneum. If any of those were abnormal, then I would remove the varies and replace it. If I felt like the varies, yeah, go ahead.
Go ahead. No, go ahead.
I was going to say if they felt that the varies was in the wrong position from one of those, then I would remove it and change techniques to a more direct approach. And once I was in the abdomen to visualize, I would check the underlying bowel or additional organs.
But let's say you were initially in the bowel, you took out the varus. How are you going to be able to see any defect in the bowel from the varus because it's so small?
Normally you can't, but you can see if you had insufflated gas in the bowel in that area. And
But you
then I
wouldn't
would,
have insufflated because your opening pressure wouldn't be appropriate, correct?
yes, but if I had started to insufflate, sometimes a little bit of gas does go in. So you may see some part of the bowel that might be slightly distended. If I was concerned and I wasn't sure, then I could call general surgery to evaluate if I thought I had injured the bowel with the varies needle. But you're right, the incision is very small, so you may or may not even see any injury.
So let's say you did have a bowel injury, and let's say it was a little bit bigger than just a pinhole. So it was let's say it's a couple of millimeters. How would general surgery repair that?
So they would probably feel comfortable repairing that, you know, laparoscopically. They would repair it perpendicular to the long axis of the bowel, depending on the way the incision or the trauma had occurred to the bowel. And you could do it in like, you know, 1 to 3 layers using interrupted sutures of delayed absorbable.
So go through how they would repair that. Go through how they repair. Let's say it was a small bowel that got injured.
Okay. And so like I said,
you call them, let's say you call them and you say, I'm concerned I had a small bowel injury. They'll come in and what do they start doing? You tell me what they would do.
So first, I think they would evaluate the bowel to see where the area of the injury was and if there's any other associated by running the bowel. So lifting the bowel, inspecting the surrounding areas, seeing if there's any other areas of injury, you know, running the entirety of the bowel to see if there's any other areas where there's been injury, inspecting like the serosal for any like thermal injury, depending on what I had been doing in the operating room. So after they identify the injury, then they would evaluate for closure and, you know, evaluate for any spillage of bowel into the abdomen. They would position the closure. So like I said, it would be perpendicular to the long axis of the bowel, which you can place a suture to correct the angle of the laceration so that it's like perpendicular, and then close in interrupted stitches using either like a Vicryl or a silk, and that can happen, like I said, in 1 or 2 layers, making sure that the interrupted sutures are close to each other to make a watertight seal.
So you said you use silk. Where would you use the silk?
I'm sorry?
You said you use silk suture?
My understanding is that general surgery, they will either use delayed absorbable or silk.
Where would they use the silk? To repair the entire bowel? The muscularis, mucosa?
No, I think my understanding is that they would use the delayed absorbable for the mucosal layer, and that they would use the silk for the external muscular layer.
Now, when you're putting the varus needle in, do you angle it a certain way in your
So
cases?
it depends on the body habitus of the patient. If the patient is very thin, then I may angle the Verey's needle once I hear the position is corrected before I towards the pelvis at a 45-degree angle. However, if the patient is obese, then I would not.
Why not?
Because the distance between the layers of the peritoneum and the great vessels is slightly longer, whereas patients who are thin, there's a slightly higher chance that you could potentially nick the great vessels by not having any angle for placement of the Verey's needle.
So let's say you put a Verey's needle in and you get blood return. What would you do?
So then I would be concerned that I injured a vessel on placement of the Verey's needle, at which point I would alert the OR staff that I would need to transition from a laparoscopic approach to a laparotomy because of the blood that has returned from the Verey's needle.
And would you remove the Verey's or keep it in place?
I would keep it in place.
What is
At least
Palmer's
till
point?
identify the bleeding. Palmer's point is in the mid-axial region of the, mid-axial line, 2 centimeters below the last rib on the patient's left upper quadrant.
And why would you use Palmer's point?
So Palmer's point can be used if there is a patient who has mesh around the umbilicus or some concern of additional adhesions in the pelvis that may distort anatomy, or if there's concern that the patient has a prior history of multiple either bowel surgeries or bowel infections that could, again, distort placement of the anatomy. So Palmer's point would avoid some of those complications with placement.
So in this tubal, you did a bilateral tubal fulguration. Why?
So at the time when I did this case, that was the practice. I have updated my practice since that time, and I prefer if a patient desires to have a sterilization procedure to do a bilateral salpingectomy, understanding that that either way this is a permanent procedure and that they should not be using this as some sort of alternative to a shorter acting contraceptive if that was their thought.
So what type of fulguration did you perform? What type of cauterization? And why?
You mean like bipolar? Is that what you're asking about? Yes. So we used a bipolar for the fulguration process for hydrolysis of the surrounding tissue and coagulation of the fallopian tube.
And can you tell me the 10-year failure rate of different sterilization methods through, as was noted in the cress study?
So I believe that for fulguration, that I performed, the 10-year pregnancy rate was like 1 in 1,000, and I do remember that Fleishy clips and ring were also studied, but I don't remember the exact rate of failure.
So in the cress study, which method has the highest failure rate? Let me put it this way, before we go there, tell me the different.
So the fulguration had the highest failure rate, I believe. Tell me
the different types of sterilizations you can do.
For just females, you mean, I'm assuming?
Yes, novasectomy, yes.
Okay.
As was mentioned in the cress study.
So the options that were studied in the cress study were a titanium clip, like an occlusive device, like a ring, like a falop ring, and then like a fulgurative or cauterizing procedure.
So of those, which has the highest failure rate?
So from the initial cress study, I believe it was the fulgration, but I think there was some newer data that it wasn't as high as initially believed, but I don't remember the exact numbers.
So which has a better, because you said the titanium clip or the filshy clip, and then you said the ring or the falop ring, which has a better or higher failure rate, the falop ring or the filshy clips?
The ring.
Has the higher failure rate?
Yes.
Okay. And what about between a bipolar fulguration and a postpartum tubal?
I believe the failure rate is higher for the fulguration than a postpartum tubal.
And now, do you know the difference between the failure rate of a bipolar fulguration and monopolar?
I do not. I would have to look that up.
Now, you said that she had a malpositioned IUD. How was it malpositioned?
So she had a placement at a different clinic. So she had come after, subsequent to that placement, for repeat discussion for contraceptive care, at which point it was noted that the IUD was partially visible at the cervix, and she wanted it removed because of discomfort, and she didn't want to have a IUD replaced. She wanted an alternative long-lasting contraception, and she also expressed that she no longer wanted any further children.
So the IUD was removed in the clinic or during the case?
The IUD was removed in the clinic separate from the case. It would have been more ideal to remove it at the time of the procedure, but she was very uncomfortable and it had caused her a lot of pain. So it seemed more patient appropriate to remove it at that time.
So let's say, let's change the story a little bit, and let's say the patient was 22 years old and she had had 3 prior vaginal deliveries. How would you counsel that patient in regards to permanent sterilization?
So a patient who's under the age of 25 have a higher chance of regretting a permanent procedure like sterilization, and alternative contraceptive methods like the IUD or the implant have even better or lower rates of pregnancy prevention. And she could reconsider sterilization at a future time if she changed her mind, or she, still continued to desire sterilization, but that because of her higher regret rate at such a young age, it may not be the best decision.
And let's say she's like, I know what you're telling me, doc, but I want permanent sterilization. Would you go ahead and do the tubal or the salpingectomy now?
As long as she was consented and understanding, then yes, I would.
And what's the risk of sterilization regret?
It's highest in patients under the age of 25. I think it's 20 to 30%, but I would have to look that up to confirm.
All right, very good. Let's stop there. How'd you feel?
I don't remember GYN.
I think you did pretty good.
Okay, thank you.
Realistically, you don't really, and before I forget, I know some of the other candidates, they said we, always I. I can't recall if you said that yourself, Jennifer, but everything's I did this, I did that. I know it's hard, you know, being, you know, one of the junior partners in a group or what have you. You have senior partners, but everything you should say is I did this, I decided this. So you really don't need to know really that many studies. Cress study you should know, WHI study you should know. And I know for a fact a candidate got specifically asked questions in regards to the cress study, even though she had salpingectomies as tubal methods. She had no falop ring or Filshie clips, nothing. And they asked her questions in regards to the cress study. So you don't have to know that many studies, but like the WHI, the cress study, you should know.
Yeah, thank you.
So the 10-year failure rate of the cress study, of course, depends on where you get that information from. Monopolar is 7.5 out of 1,000 procedures. Bipolar is 3.2 to 6.3 out of 1,000 procedures. Postpartum tubal is 7.5 out of 1,000. The hulka or the spring clip is 36.5 out of 1,000. So the one that fails the most is actually the hulka clip. The falop ring is 17.7 out of 1,000. Now, Filshie clips were not included in the initial cress study because they hadn't been invented yet, to my understanding, because they were not used in the USA at all. It was done in Europe, so it was not part of the study. However, the failure rate of titanium clip is based on studies with 6 to 15 years follow-up that's comparable, and it's a failure rate of 0.4%. So better than some of the methods that they use in the cress study. So realistically, if you did an extrapolation, Filshie clip is the best method, supposedly. Again, might be a moot point because everybody gets a bilateral salpingectomy, right? Every now and then you may have somebody who culturally does not want anything removed from their body, so they may opt for a different method and not get the salpingectomy. In regards to bowel injury, you repair the laceration if it's less than 2 centimeters in size. If it's greater than 2 centimeters, you should consider resection. And realistically, if you put in a Verus needle and you think you're in the wrong place and you may have been inside an organ, you leave it in place because you may not be able to find the injury. Am I making sense?
Yeah, that makes sense.
Okay. So if you have the injury parallel to the long axis of the bowel, you close end to end, and that avoids narrowing of the lumen. You use the mucosa muscularis in a single layer with interrupted 3-0, and the muscularis serosa with 3-0 non-absorbable suture. And that's where you use the silk, because initially it made it sound you used silk throughout. That's why I asked you. You do not, because you can't have non-absorbable suture within the lumen of the bowel. That'd be crazy.
Right.
If the lacerations are right angle to the long axis of the bowel, you close side to side. The bowel closure should always orient the line of laceration perpendicular to the long axis of the bowel, like you said. The Palmer's point, it's not mid-axillary, it's mid-clavicular.
Okay, I was trying to remember and I couldn't.
It's mid-clavicular. Whenever in doubt, you go in the Palmer's point. Okay. Any other questions in regards to what we discussed? I think we went over the major points.
Yep, that was really helpful. Thank you so much.
No worries. Any other questions?
No.
Okay, very good. Thank you for participating. So I'm looking down the line. We are past time, guys. I want to see if anybody has any questions about anything that was discussed or anything in general. Anybody have any questions about anything? Just looking down the line here. Agustina, looks like you have a question.
Yes. Yeah, can you hear me?
Yes.
So for the mirena IUD and other kinds of long-term contraception, there's a FDA approved term of usage, and then there's the general, like the FDA approved mirena for 5 years, but it can be used for 7 years. Do we mention the FDA approval or mention the general use, or you can say either one and it goes?
I would preface by saying the FDA has approved this for this
Okay.
amount of time.
Okay.
Because they've been saying for years that you can use a mirena for 7 years.
Yeah, and I
This is
know
different. Yeah. But
some
then the
people
thing is, let's
use it.
a patient ends up pregnant. You know what I'm
Yeah.
saying? You have a leg to stand on. You know what I'm saying?
Okay. So
So
go with
there's and
approved length of.
so as long as you preface, to my understanding, FDA approval is for this. And it's kind of like what I have seen in my experience is the Paragard. Paragard
Yeah.
is good for 10 years. But I do know many providers after 5 to 7, they actually will put a new one in because the longer you have the Paragard in, the more the inflammatory process increases and you have a greater risk of bleeding. I've actually seen patients almost need transfusions because especially the longer they have a Paragard, I'm talking about 9, 10 years in, because it causes that inflammatory reaction and you could bleed more. So that's why I know some providers, even though it says it's good for 10 years, some people will take it out sooner in order to avoid that problem. Does that make sense? And
Yeah.
that's anecdotal in the sense that, if it was confirmed 100% that you're going to bleed a lot more if you have it in place for 9 to 10 years, then they won't allow it to be in for 10 years. Does that make sense?
Yes.
So yeah, you would say you preface, or you could say, in my experience, I've noticed this. I discuss it with patients, and if the insurance pays for it, you could switch it. I'm talking about the Paragard.
Yeah.
But yeah,
Okay.
you could preface by the FDA, because if you do anything a little bit different than like the manufacturer, back it up. In the end, I'm not saying what anybody told me was right or wrong. It's you must defend. Sometimes you defend it wrong, but you must defend why you did what you did for the patient. That's what's key. In essence, they want to pass everybody that takes this exam. Everybody's going to walk in probably. This is the way I see it. Even though it's very hard when you're studying, like, oh no, I've heard horror stories about this exam and this, that, and the other. It is yours to fail, so to speak. They want to pass you, but when you start shooting yourself in the foot, that's where you fail. Does that make sense?
Uh-huh.
You don't go into the exam. They don't want to fail anybody. They want to pass everybody. But when you start, opening your mouth and have diarrhea of the mouth, and you start talking about weird things, that's where you lose it. Or if you have
Okay.
attitude towards the examiners, I don't care how smart you are, you will fail.
Okay.
In my, in my residency, there was a guy in my class who had a photographic memory. So when you talked about studies, he knew the study. He probably was smarter than the examiners, but he failed the first time. Like, well, he failed, then I don't have any chance in heck to pass. And I remember he passed the second time he took it, and I'm like, what was the difference? I was extremely cocky the first time, and that's why I failed. The cockiness got him, even though he was probably smarter than those examiners. His cockiness got him.
All
They'll
right.
cut you down to size. That will do.
Okay.
That will do without problem. Okay, that answer your question?
Yes, ma'am. Thank you.
Okay, very good. All right, thank you. Any other questions? I'm looking down the line, guys. Bethany, I'm heading over there. Says you're self-muted. Can you hear me?
Yes, I don't have a
Yes.
question. I think that was left over.
Oh, okay, I'm sorry.
No, thank you.
Yep, no worries. I'm just looking down the line, see if anybody has any questions. I see Mandy has a question mark. I don't know if she has a question. Can you hear me, Maddie? I'm sorry, is it Maddie?
Yeah. I just,
You have a question?
I typically, like, for a patient that would want a myomectomy, laparoscopic or abdominal, instead of a hysterectomy, I would refer to our minimally invasive GYN. Should I still be, like, prepared to describe how you would do a procedure?
100%.
Myomectomy?
100%. Because they'll say they're not available, or they'll say, okay, I understand you're referring her to whomever. However, what would they do?
So kind of like being able to describe a TVH, expect to know myomectomy.
Exactly. So, because I know we don't do that many TVHs anymore. So the way you can hopefully put it in your back pocket how to do a TVH is to learn how to do a dictation on it. And I have heard of cases where they ask you to dictate a TVH. And if they like what they hear, they'll cut you off. You're not going to have, have to go all the way to the end. Because you're just wasting time. They're going to want you to do other things. But if you can start that up and have a good clip, they'll cut you off because it shows that you know what you're doing, and they'll move on to something else.
Okay,
thanks. Because I know a lot of people don't have vaginal hysterectomies in their list. So just have that in your back pocket and how to dictate it. Even though you may refer that patient to urogyne, they want to know what urogyne would do.
Right.
And if somebody if you did a dual procedure with somebody, like with a urogynecologist, they want to know what the urogynecologist did. So you should have some type of understanding what was done.
Okay.
Okay.
Thanks.
All right. Any other questions? Okay, I'm just looking down the line here. So I see Zishan has his hand up. I'm assuming it's from before. Do you have another question, Zishan?
I was just thinking when we talked about
Yeah.
the inoperative complication I had with the ovary bleeding, if there was a tear in the IP, if it was high on the IP, I could still do the oophorectomy, right? And that would take care of that. I'm just trying to think holistically. If they said, what if it's on the lower aspect of the IP? What would you do next? Is that where I'm headed towards calling someone for hypogastric ligation, things of that nature, or what? Just kind of thinking out loud of what I need to be prepared for if they change the scenario there.
I mean, realistically, the only reason you would, like, let's say you have like a tear in the IP, you can suture that area with a small needle, small suture to see if that would stop the bleeding. But if the bleeding continues, you're gonna have to clamp and transect the IP, right?
Right.
They're not gonna, in regards to the hypogastric artery ligation, it's interesting because when I took the exam, when somebody had, let's say, a cesarean hysterectomy, or before you did a cesarean hysterectomy, one of the recommendations, you would call oncology so they could help you do a hypogastric artery ligation in order to decrease the pulse pressure, therefore there be less bleeding. Now, newer studies, again, don't say the studies, but to my understanding, newer studies, it's not that effective. So when you before you do a C-HIS, hypogastric artery ligation is rarely done anymore. So I mean, should you know how to do a hypogastric artery ligation? Yeah, they could ask you anything, but it was much more so 20 years ago, because that was one of the things that we would do. You do your uterine artery ligation, or your O'Leary stitch, and then you went to your hypogastric artery ligation before you said I have to take out her uterus. But nowadays we have a lot more things. We have a ligature, we have all these things. So when people do a C-HIS, there's so many other apparatuses that decrease your bleeding that didn't exist 20 years ago.
Okay.
Or 30 years ago. Nobody ever thought of using a ligature to decrease your bleeding because it really didn't exist, or it was in its infancy. So realistically, if you're going to do a hypogastric artery ligation, it's going to be more so for a uterus, not necessarily for an ovary. Does that make sense?
Yes.
So if she's bleeding from the IP, there's like a laceration there, it's taking out the IP and taking out that ovary.
Okay.
Beyond where the laceration is.
Right.
Let's put it that way.
Perfect. Thank you.
Does that answer your question?
It does.
Okay, excellent. I see Tamara has her hand still up. Do you have a question, Tamara? It says you're self-muted. Just still says you're self-muted, Tamara. Still says self-muted. I'm assuming you do not have a question. Your hand is up from just the participating. I'm just going to go up the line here. I see Jennifer has her hand up. Do you have a question, Jennifer? Or was from before?
I just have a quick question. You had mentioned about the crest and the WHI study.
Yeah.
If during the test, let's say you just blank out and forget something related to one of those studies, and you're just like, this is what I remember, I don't remember anymore, are you going to fail the exam, or is this like...
No, not at all. You may not get full points at that particular question or section. Does that make sense?
Yeah, so just say like, I don't remember, I would have to look it up.
This is what I remember at this. This is what I remember at this time. I'd have to get back to you for the other things that I'm forgetting. You always say, I'll get back to you if I can't remember something. It's human nature to say I don't know for many things. Like, for example, if they ask you, I'm going to make this up. If they ask you, and I've said this before during the webinars, if they ask you, can you tell me the staging of endometrial cancer? If you don't know the staging cold, the first thing you want to say is like, I don't know. Well, that's 0 points. But then that's where test taking strategy and technique comes into play. You could say, you know, off the top of my head, I cannot recall all the stages of endometrial cancer. However, I do know that stage 1 is confined to the uterus and stage 4 is distant metastasis. You're going to get partial credit for that, and that's smart testing strategy. Again, it's human nature to say, I don't know, if you don't know it specifically, especially most docs are type A personalities, right? So we're very anal. So if we don't know the answer, we're going to say no. So you have to be smart and temperate by saying, you know, I don't know all the stages, but I do know some of them, and these are the ones that I know. So you're going to get partial credit instead of 0. The key here is to get as much credit and doing things as possible. That's smart test taking strategy.
Okay, thank you.
Make sense?
Yes.
And I always say, you know, and I'll let you know, and I have to look up the other 2 stages, and I'll get back to you with that. You're never going to see them again, but it's a nice way of saying I'll look into it.
Okay, thank you.
All right, very good. Any other questions? I'm just looking down the line here. Tamara still has her hand up. I don't know. It still says she's self-muted, and I'm not able to undo it.
My mistake. I'm sorry.
Your mistake? Okay, now you're working. Okay, cool. So no questions.
No questions.
Excellent. All right, very good. I'm just looking down the line, see if anybody has any other questions. I don't see any other. Excellent. Well, I really want to thank the candidates that participated. I think you guys did a great job. I mean, I know probably many people on the call have their exam coming up in November. So it's time, crunch time, guys, to really start buckling down and focusing. Time to be doing lots of mock orals, and not necessarily through any board prep, colleagues, you know, other people that you know that are taking the exam. You can, you know, bounce things back from, you know, from one another. But it's time to verbalize as much as you can in regards to the questions. We're all, everybody on this call is extremely smart. You know, you would not get to this level, but this is a completely different exam than we've ever taken, because the key here is verbalization, discussing and saying what you know, and that's where it's much more difficult. So practicing, practicing, practicing. I know it's embarrassing to be on the hot seat and get things wrong, especially during the structured cases. So the Monday and Wednesday sessions. However, that's how you're going to learn. You want to mess up here doing the webinars and not in the exam in real life, because you want to pass that exam. You don't want to be collecting these cases again. This is a year of your life that you spend doing a lot of stuff to prepare for this exam. So you want to pass first time around. So practice, 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 practice is all I can say. Do as many mock orals and verbalizing your knowledge. So I'm going to say one more time, anybody have any questions? I'm just looking down the line. Nobody has their hand up. So again, I want to thank Zishan, Tamara, and Jennifer participating. I think you guys did a great job. I know we have a webinar tomorrow, will be structured cases. Hopefully everybody will be able to join the call, and I wish everybody a good luck in continuing in their studies and a good rest of the night. Thank you.